This patient has a white dense cataract. For these cases, you'll want to use vision blue for better visualization. Okay, I'm going to get rid of the vision blue and then add dispersive viscoelastic. You always want to check for intumescence, so I'm using a 27 gauge needle on a 3 cc syringe, but I didn't encounter any liquefied cortex. Next, I'm going to create the main incision, add more dispersive viscoelastic, and then I'm going to make my capsulorhexis. You want to make the capsulorhexis as large as possible for these cases, so the bigger the cataract, the more dense the cataract, the bigger the capsulorhexis should be. Why is that? Should you need to convert to manual small incision cataract surgery, that larger capsulorhexis will help in removing the endonucleus. I'm going to now basically go ahead and make a large trench, and this will give me a good working space. And you want to sculpt as deep as possible just to get rid of that fibrous leathery plate. You can see there's adequate separation, and I'm just making sure that there's a full 100% separation. Now with mechanical fracturing forces, I'm able to break the heminucleus entirely on position 1, so there's no vacuum being used during that step. And now I'm just going to remove each quarter of the heminucleus, and notice how I just keep the phaco tip right in the center and the chopper does everything else. And here again, I'm not using much ultrasonic energy, I'm just sandwiching the piece using the 2 instruments. And at this point right now, as you get rid of more and more pieces, you'll see more and more of the posterior capsule being exposed. So you want to actually lower your vacuum. And so now we've got the remaining heminucleus. Now the remaining heminucleus, as you'll see, is very slippery, wants to kind of move around within the capsular bag, and you want to be mindful of that because it has sharp edges. Here you see I've separated it, and now I've got 2 quarters. And once again, I'm going to sub-chop and lower my vacuum. Alternatively, what I could have done is the scaffold technique, where as I'm left with one quadrant or 2 quadrants, is just to slip the IOL into the capsular bag, preventing the posterior capsule from coming back. So here again, with my phaco machine, I've lowered the vacuum settings, and this really prevents that posterior capsule from coming up. You're basically reducing the risk of post-vacuum surge. You can see I'm just nudging with the chopper. The chopper is doing almost the majority of the work, whereas the phaco tip is just staying in the center. Now with these white cataracts, the posterior capsule is very thin, very friable. You'll always see very thin strands of cortex. I don't chase after every single strand if I'm dealing with a white cataract. Here I've added cohesive viscoelastic, I've placed the IOL in, I'm removing the viscoelastic, and I'm hydrating my incisions. I hope you found this video to be useful, and thanks for watching.